Here we go. So, on behalf of Department of Gastroenterology of Sir Gangaram Hospital, New Delhi, and Delhi Liver Foundation, I welcome you all to this webinar on obesity. So, while we are dealing with the COVID-19 pandemic, we are waiting for it to get over in next few months with the introduction of vaccine. We will still have to continue fighting with the pandemic of obesity, which is getting worse and worse with each passing decade. And also, there is no vaccine for the obesity for it to get over. The only thing we can do is to understand it better so that we can try and prevent obesity and then treat it better. So, in this endeavor, we had planned a series of webinars on obesity, and today is the second webinar of that series. In the previous webinar, we had tried to unravel what is the etiology of obesity and what are its genetic and environmental basis. In today's webinar, we will discuss the history of obesity and how do we define obesity and what are the different types of fat. So for today's webinar, we have two eminent moderators who need no introduction to this audience. One, Dr. Yogesh Chawla, who's the ex-director of PGI Chandigarh, and Lieutenant General Dr. A.C. Anand from the Army. And both of them are presently at the Kalinga Institute of Medical Sciences, Bhubaneswar. Here, I would also like to add that uh, when we used to have the normal conferences every year, we used to honor Dr. S.K. Sama Memorial oration we used to give. But since we are not having regular conferences, so we decided that every 2 months we will honor eminent gastroenterologists from India from each state. So last time we had honored Dr. M.P. Sharma for the S.K. Sama Memorial Award, and we are skipping this month. So every 2 months, so next month we'll again have this felicitation of some eminent gastroenterologists from some state. So I would now hand over the proceeding to our moderators, Dr. A.C. Anand and Dr. Yogesh Chawla, to introduce the speaker and begin the session.
Dr. Chawla, sir.
Thank you, Ashish. It's a pleasure to be a part of this symposium on obesity, a very important topic. And it would be my pleasure to introduce Professor Anil Arora, who is the chairman of the Institute of Digestive Diseases and Pancreatic Biliary Sciences at the Gangaram Institute in Delhi. He has been a product of All India Institute, has done a lot of work in the field of gastroenterology and hepatology. And I would like to invite him to talk to us on the history of obesity. So Anil Arora, please.
Thank you, Dr. Chawla. Are my slides visible?
Yes, we can see your slides.
Yeah, good evening, everybody. All those who have joined the webinar, second webinar on obesity. My presentation is going to be on history of obesity. Greetings from Sir Gangaram Hospital. Being fat, is it good, ugly, or bad? I'll just take you through the history of obesity as to what does it mean. In fact, the term obesity propped up in Oxford English Dictionary, and it was documented way back in 1611 by Randall Cotgrave, who was an English lexicographer who compiled a bilingual French and the English dictionary. Obesity colloquially means obestias, which means stout, fat, or plump. Esus is the past principle of adhere, that means to eat with ob added to it. So if you add ob to adhere, it becomes obesity. That means overeating. But surprisingly, it took us almost 500 years to understand that overeating may be a problem. And only today we do realize that it has become a worldwide health issue with high incidence and prevalence. And today we believe that obesity is a medical bomb which is awaiting to be diffused. So let's start with the first question. Once upon a time, being obesity and being obese and being fat was a privilege. Was it really good to be fat? I'll give you 5 major reasons why it was supposed to be good for fat. In fact, it was, if you were obese, you were the only guys who were surviving. So it was a question of survival of the fittest, which has the roots of obesity during evolution. In ancient time, there was shortage of the food, and hence human mankind had to travel for ages to get the food. So this led to the hunting to catch hold and to store the food that was available scarcely. So the energy which was available from the food had to be stored as fat to cope up with the long periods of the time during which the food was not available. So the organisms which were able to store their energy in the form of fat for a very long period of time were able to survive and others vanished. Classical example is this trans-Siberian birds who would have to fly for 6 months to catch their prey across the Atlantics. So this led to natural selection of the excessive fat, that is obesity genotype, as a mode for survival. Secondly, it gave us a genetic advantage. Being fat gave us a genetic advantage. How did it give us? Let me explain you. Let's see the example of the Paima Indians. Now, the Paima Indian tribe lives on the Gila River Indian Reservation in Sacaton, Arizona. They are now famous for being fatter than any other group in the world. In fact, if you look at the Paima tribe, which is located in the Arizona in this region of the US, 50% of the people above the age of 35 are diabetic, which is extremely high prevalence and incidence of obesity in this subgroup of the individual. So what explains this obesity in the Paima Indians? The non-Native American poverty-stricken tribe who were struggling in the scarcity of the food, only those who could store the fat survived, rest all vanished. So before 1695, it was the need of the hour that those who were fat would be able to store the food and hence they survived. Rest all possibly vanished. Subsequently, in 1820s, the Paima Indians were invaded by Anglos. And with the constant industrialization and introduction of the refined carbohydrates, that was a part of the staple diet which was provided to the Paima Indians. So the Paima Indians, by default, because of their existing genetic evolution, because of the presence of the thrifty genes, they were now fed with industrialized refined carbohydrate, which led to the victimization of these so-called Paima Indians. So a combination of the thrifty gene, which were at present an important asset of their living, it became a liability. So this is called a thrifty gene hypothesis. And it is for all of us to see that those Paima Indians who had underlying thrifty genes as a part of the evolutionary escape mechanism to escape from the death and the poverty, when they were given a diet containing refined carbohydrates, look at the way they have grown up in their body fat and mass. And today, 50% of these are diabetic beyond the age of 35 years. In olden times, obesity was seen to be a part of being a well-being. The classical example is the Venus of the Willendorf, which was discovered in Australia in 1908. And it was considered to be a matriarchal icon of fertility or the mother of the goddess. This was discovered in 1908. What does it depict? If you interpret this image which I have shown you, it tells you about the Venus figurines. It is a depiction of the nude women with exaggerated sexual features, a squat body with bulbous contour, pendulous breasts, and prominent body. And it represented an early fertility fetish, perhaps mother goddess. So it was commonly known as the Venus of Willendorf, which was discovered in 1908 in Australia. Third reason why obesity was thought to be good was the cultural connotation. In fact, the painter Rubens always would depict the full and rounded women as somebody who was Rubensic. That means something which was plump. It was in terms of pleasing and attractive way that these plump women were referred to as Rubensic. But subsequently, the sense prevailed, and in 1825 to 1905, slim cupids or the borigi were considered to be better in the latter half of the 19th century. Then you have examples of the US presidential election, which we have just seen. In the 31st presidential election, the president gave the following information on his play card. a chicken in every pot and a car in every garage. So this was the election manifesto of the president called Herbert Hoover. But look at what happened in 2016. A chicken in every car and pot in every garage. Thereby meaning by that time, by 2016, even the presidents and the people in the US have realized how bad it was to be fat. This further reflected through the American presidents in the first and second half of the 20th century. Look at the way you had opulent presidents in the initial part of US presidential election. Look at the Grover Cleveland, William Taft, and Herbert Hoover. All of them were plump. They were showing signs of opulence in the first half of the 20th century. And subsequently, in the latter half of the 20th century, look at the figures of the American president. You have John F. Kennedy, you have Ronald Reagan, and you have George Bush. And everybody knows the story of the 46th president election, which was conducted only about a week ago, and in which we know the weight does matter. And if you look at the weight of the Joe Biden and Donald Trump, it is always easy to understand that certainly the weight today is a liability, not an asset. So, ladies and gentlemen, a combination of the scarcity of the food throughout the human history, to being fat was good and flesh was desirable to escape the clutches of poverty and lack of food. It was reflected not only in terms of the art, literature, but also the politics of all time. And hence, fat at some time was good. But then how did the fat suddenly become ugly? Only in the latter part of the 20th century did it become stigmatized. And then before becoming bad, being fat underwent through a process of being ugly. Let me give you some examples of that too. In fact, first reflection of fat being ugly came way back in 1837. If you remember this famous novel by Charles Dickens in his fictional work as a wonderfully fat boy, which was presented in 1837, one of the most popular novels. When the same novel character of the good man called Joe was played by this actor called Marty, when he played this actor of fat boy, he attributed his rejection by the girls to being an ugly man. So by 1953, people realized that if you are woefully fat, you will be an ugly man. And the passion for slimming reached a frenzy by the middle of the 20th century when the supermodel Twiggy burst into the fashion scene and became a teenage icon. Let me give you the story of this girl called Twiggy. She was from Italy. In fact, in earlier times, it was more important for a woman to have the features which are shown on the right side. You have to have thick thighs. Ideal women was an hourglass shape with a wavy hair, a pretty name, and a nurturing soul. A woman as sexy as Marilyn and as demure as Jacqueline was considered to be the more front women in 1967. Till this came in. This lady called Twiggy, she had no breasts, she wore white lipstick, her nails were bitten, her shoulders were bony, and hair were cut like a boy's. She was a negative image of everything which was supposed to look like a opulent woman. But thanks to her success story, this path-breaking supermodel called Twiggy changed the scenario of fashion industry starting in Italy and France. She landed at the Kennedy airport in March 1967 in the spring and the summer of love, and the fashion changed forever. In the summer of the love at Kennedy airport and in the surrounding areas, there was a social phenomena that occurred during the mid-1967 when as many as 100,000 people, mostly young people, sporting hippie fashions of the dress and the behavior changed. So Twiggy became an instantaneous icon of success, a symbol for a new kind of women with a new kind of streamlined androgynous sex appeal. Then came the time to realize and accept the fact that fat was not only not good, but it was ugly. And then people started realizing, is it possible that this ugly fat may become bad also? So how is it that the fat became bad? There are some anecdotes for centuries. Let me give you some examples. The gross obesity of the mother goddess, which I had shown you as Venus of Wellendorf, that did not last long. There were evidence from the Hippocrates corpus, which attributes fatigability to excessive weight. And there were 1660 books written by Greek medical works which talked of this. Record of the Spartans who ostracized the fat men from their army because fat men could not fight the battle very well. And you had this gentleman called Socrates who would dance every time he would find time to maintain his body figure. So the Spartans will chuck out all those men who were fat since they could not fight their battlefields very well. And you had Socrates who would have leave this body supple. He always recommended easy and healthful should learn to dance as long back as centuries ago. And then we had first medical consequences and the writings which were given by William Cullen. He noticed medically for the first time that those people who were fat would have fatigue, they would have gout, they would have breathing difficulties, but it was not documented in the medical literature. Then we have the story of TPAs, which we ridicule on day-to-day basis because they create so much of hurdle in reimbursing our patients. By 1992, companies in the US, in different medical companies, insurance companies, did analyze that the biggest sucker of their funds were the people who were overweight and who were obese. Pickwickian syndrome in 1956 was a classical example in which all of us know that a combined syndrome of obesity-related hypoventilation and sleep apnea in this Charles Dickens novel, The Pickwickian Paper, and this was the guy who will fall asleep constantly during the day. So Joe's sleep problem is the origin of the medical word called Pickwickian syndrome, which was the first association of the obesity with the ill health of the human being. But if you go back to the history of the medical records of the ill effects of the fat, they were recorded for the first time by William Osler in 1849 to 1929. He attributed obesity to overeating, and he believed that it was little behind than drinking in its disastrous effect. In fact, as long back as about 200 years ago, he did recommend that we should have low refined carbohydrate diet and eggs as a part of our feeding. And subsequently, as more and more science came into being, there were major contributions from two scientists in the Germany and one scientist from the United States. So they look at the scientific aspect of nutrition in an effort to define the nutritional components, the metabolism of the components, and the thermodynamics of the food which was needed for the body. So what they realized is that in the later half of the 19th century, that there was a connection between the body heat generation and the muscular work and the conversion of the food into energy. So nutrition was now quantifiable. It was expressed as food values in calories. And calorie count rather than spoons and cup was now referred to as in terms of quantitative assessment in terms of consumption of calories. So by the end of the middle 20th century, overeating was related to depression, hypochondria, and melancholy. In 1960s, body fat was defined as an organ with its own hormones, receptors, and genetics. And further, later on, nutrition emerged to be one of the important components of the science which defined the way we look at the obesity today. And thanks to this changing paradigm, we have newer definitions which were given to various societies which were trying to look at the nutrition and obesity. These were variously named as National Obesity Society, which was renamed as a National Glandular Society, then was renamed as American College of Endocrinology and Nutrition, American Society of Bariatrics, American Association of Bariatric Surgery, and then American Association of Bariatric Physicians. That only shows how the society was viewing the various components of the fat, whether it was a society, endocrinology, bariatric surgeon, physician, and whatnot. So this was the changing paradigm. And then at the same time, we had this Belgian physician. He was an astronomer, mathematician, statistician, and sociologist who devised this concept called BMI between 1830 and 1850 as what he called as a social physics. So this gentleman called Adolf Quetelet was not a physician. He tried to calculate the average attributes of a normal human being. He was a racist by definition. He calculated this index of body weight and height as a social index. For its inventor, the BMI was a way of measuring population, primarily white population, not an individual. It was designed to be a statistical tool, not for individual health. And then it was meant primarily for the white people, in which was done primarily French and Scottish, exclusively for white people. It was never used as a measure of obesity and ill health. In his honor, the Belgian did issue a stamp in honor of Dr. Adolf Quetelet. But the modern term body mass index, which was basically a part of his research, it was for the ratio of the human body weight to the scaled height, was coined in a paper published in July 1972, edition of the Journal of the Chronic Diseases by this gentleman called Enkel Kais et al. In 1972. And finally, and now we know, all of us, we almost have daily webinars on this. Obesity, metabolic syndrome, and frank NAFLD are just intertwined processes. One can lead to another, and you know all the consequential effects of that. To summarize, ladies and gentlemen, we know that obesity at time was considered to be good because it was the reason for you to survive. So that led to survival of the fittest. It gave you genetic advantage of living over and above others who could not survive because they could not store fat. It was supposed to be a sign of prosperity and well-being, and it also was a sign of opulence and cultural connotation, as even manifested in the president's elections campaign way back in US. Subsequently, the same thing became ugly when people realized that being fat became stigmatized. It was a reason for rejection by the girls. Then there was a passion for slimming, which reached new heights. And this new height was, I think we should give full credit to this girl called Twiggy from France, who was instrumental in changing the concept of the fat being ugly. Eventually, fat became bad. This is something which actually deserved to be bad because it leads to fatigue, gout, breathing difficulties, which were told to us by William Cullen in 1768. Biggest change for health insurance firms did find out that those who were obese were taking out the maximum amount of money from the insurance company. Then finally, when the nutrition science came into the being, did one realize that obesity is something which can be quantified and has deleterious effects. And now for all of us, we are so clear about the relationship between the obesity, metabolic syndrome, and vicious health. And thanks to the unmasking of the obesity, a combination of agriculture revolution, supermarkets, and e-marketing, primarily managed by Zomato, Swiggy, and other components, we have easy availability of food, and we want to preserve that in a genotype which we have already acquired to preserve the fat. So a combination of the overeating and preserved fat genes lead us to have obesity. So ladies and gentlemen, we have moved from lower incidence of obesity, which was supposed to be good in 17th century, via ugly in the last 100 years, to almost the last 70 years. We know how bad the obesity is. So as of today, in about 50 years from now, we know obesity has become one of the bad things of the human beings rather than being good and ugly of the yesteryears. So based on that, we know it has changed paradigm from being good via ugly to bad, and WHO has defined obesity as a global pandemic. With that, we have a changing timeline of small number of the people who were obese, who were opulent, who had influence, and who were having good health. They were seen in the early part of the 17th century. The number of the people with obesity increased, but then 100 years ago, we realized it was ugly. And now with increasing number of the people, almost 30% of the population in the world being obese, we know it is a bad disease, and we have realized it for the last 30 years. And with that, I'm going to thank my senior resident, who in spite of being busy in his marriage ceremony, has really done a good work in helping me have this presentation. Thank you so much. With that, I'll hand over it back to the moderators.
Thank you, Anil Arora, for a wonderful talk and giving us a brushstroke of the history of obesity. Unfortunately, obesity is a major problem, not only in the world, but has also occupied a large number of people in India. So I hand over the mic to Professor A.C. Anand now.
It's a great pleasure for me to introduce Dr. Ajay Duseja, who actually needs no introduction. He's the Virat Kohli of our hepatology circles. He has been a sheet anchor in doing research on non-alcoholic fatty liver disease and about the fat. And he's going to talk to us that fat is not just a ghee tin, but it is also a live tissue. And what are the different types of fat and what is the clinical implication of each type of fat? Dr. Ajay Duseja.
Let me first share my screen, and are my slides visible and on full screen mode?
Yes, they are visible.
Okay. Thank you very much, sir, for that kind introduction, and my sincere thanks to Delhi Liver Foundation and the Gangaram team, Professor Anil Arora and his other colleagues for giving me this opportunity to be part of this wonderful symposium on obesity. And my job is now to take you through different types of body fats and its clinical correlates in next maybe 15 or 20 minutes or so. I think very elegantly Professor Arora has told us about the history of obesity. So I will also start with that. When we talk about obesity or body fat distribution, I think these are the common terminologies which are used, where we call it as truncal obesity, which usually means that there's excess of fat or adipose tissue on the trunk, which is thorax and the abdomen. Or we call it as a peripheral, obesity, which means that your upper and lower extremities, the fat. Also, if you go back to the history, people do divide obesity, something like what they call the male obesity, or typically the apple-shaped kind of obesity, also known as the android obesity, which has been very closely linked to insulin resistance, diabetes, and cardiovascular disease. And probably now we know that this is probably the more of abdominal kind of obesity, and we'll discuss more on this. Also, people said something like about gynoid obesity, which is also typically called the female obesity, again the kind of the pear-shaped, and which was less commonly associated with all these metabolic complications. And now we probably know that this is probably more of subcutaneous adipose tissue, which people were earlier talking about. So more scientifically, if we have to look at the classification of body fat distribution, which I have been asked to do, I think the literature says that you have a subcutaneous adipose tissue, SAT in short, or you have an internal adipose tissue. And then there are certain ectopic sites which are not normal sites for fat deposition, but then when there's an overflow of fat, the fat goes and gets deposited there. So these are the ectopic sites. In the internal adipose tissue, they have divided into intrathoracic and intra-abdominal. And further, the intra-abdominal, the subcutaneous has been divided into superficial and deep, and the intrathoracic as around the heart or pericardial and perivascular, and the intra-abdominal, which is also known as I said, the visceral adipose tissue, has been divided into intraperitoneal, which basically is constituted by the greater omentum and the mesenteric fat, and extraperitoneal, which is the preperitoneal and the retroperitoneal. So I think this is the classification which most of the literature would agree on. And giving you the picture, the pictography of this body fat distribution again, I mean, this is what they say. This is the, the subcutaneous fat, which is the superficial subcutaneous fat. Then there is a layer of fascia here, and then this is the deep subcutaneous fat. And rest all is the intra-abdominal fat here. And in the intra-abdominal, this is the greater omentum. This is the mesenteric fat, and this is the retroperitoneal fat. So this is just the picture about the same thing which I said earlier. The ectopic fat, which I said, again, as I said, is the result of the lipid overflow or the fat overflow Normally, as I said, subcutaneous fat is thought to be the site for the deposition of this fat, the subcutaneous adipose tissue. But then, as I said, visceral adipose tissue do also contribute to that. But whenever there's an overflow, I think the visceral adipose tissue tend to increase in size, and the fat goes on to the certain other ectopic sites, and some of these include, we know, the liver fat, the myocardial and the epicardial, muscle, kidneys, pancreas, and various other organs. And all this ultimately leads on to the syndrome of what we call the insulin resistance, and increases the cardiovascular risk and various other complications, which obviously we would be discussing. Now, what are the determinants of this body fat distribution, which we just discussed? That, I mean, you have a subcutaneous adipose tissue, you have the visceral adipose tissue predominantly, and then the ectopic fat distribution. So what are the determinants? So I think this is dependent on various factors. And then to summarize, what I have written here is the age, gender are very, very important factors, and maybe we'll have some discussion on this. Your race or your genes are also determinant of the kind of body fat distribution you are going to have. And finally, I think the, as I said, in addition to the genetic factors, the environmental factors are very, very important. And in environmental factor, other than the physical activity, both overnutrition and undernutrition actually has been shown to be associated with the kind of body fat distribution. And we will discuss something about this, you know, the fetal malnutrition and the high fat diet and the role of gut microbiota, a little bit on that. So this is what I'm trying to show in this picture, is that as the age advances, I think we all are getting aged now. So as the age advances, we all tend to gain a little bit of fat. And this fat would, you know, come in both at the subcutaneous area as well as in the visceral adipose tissue. So both, I think, as the age advances, I think this increases. But the difference is that I think premenopausal women, I think they tend to have, you know, more of subcutaneous adipose tissue. But in the but the men predominantly would have more excess of visceral adipose tissue. But then as the age advances, the visceral adipose tissue obviously increases. And in postmenopausal also, I think the visceral adipose tissue increases more than it was, say, in the premenopausal period. This is again to show you again the gender differences here. So in men, again, if you look at the subcutaneous and the omental or the visceral fat, they are almost the same. And as the age advances, both subcutaneous and the visceral adipose tissue would tend to increase. But in women, predominantly it is the subcutaneous, you know, fat which is there in early years of life. But then as the age goes by, I think the omental or the visceral adipose tissue, you know, it tends to, you know, increase. And later in the life or in the postmenopausal, I think both really come closer. And that's why I think probably there is role of some, maybe the protective effect of estrogen and various other sex hormones, which are probably thought to be protective for, you know, visceral adiposity or insulin resistance, I think contributing towards that. And then, as I said, I think your ethnicity is very, very important. Your genes are very, very important. And we all understand that as Asians or as Asian Indians, we are more prone to insulin resistance and its complications. And again, this has been shown here that if you look at the ratio of the visceral and the subcutaneous adipose tissue, I think, and if we look at the compare both in men and women, the Asians obviously are more prone to have or more likely to have visceral adiposity and more of insulin resistance and more of insulin resistance related complications in comparison to the other races. And as I said, a lot of genes probably have been implicated into this fat distribution. Finally, coming to the, you know, which I said about the role of what we call the VAT prioritization, or the role of, you know, the fetal malnutrition. I think Dr. Arora did talk about the, you know, the how the things have evolved over the years. So I think this is again a lot of literature saying this, that if there is a fetal malnutrition and this is predicted, say, lifelong, then just to prevent from, intra-abdominal infections, the body would invest more in the visceral adipose tissue. So now if that, malnutrition doesn't happen in the childhood or in the adulthood, and there is excess of, nutrition which comes in, so there's something called catch-up kind of a growth which happens. But then that those whole calories, because as I said, the visceral adipose tissue was kind of prioritized from the, fetal time, I think this tends to, get bloated, tends to get bigger, tends to get more inflamed, and that probably leads on to the abdominal obesity and its chronic inflammatory state and all the complications and the metabolic syndrome which we talk. And here also, as I said, I think this was about the fetal malnutrition or poor nutrition which was contributing to this. But the overnutrition with fat and the sugars, what we know today, which we know that they do affect our gut microbiota, and the kind of changes which happen in the gut microbiota, they tend to increase the gut permeability and causes the gut to become more leaky, more of endotoxemia, and that can aggravate this ongoing inflammation in the visceral adipose tissue and sets the stage for chronic inflammation and, as I said, the insulin resistance and various other complications. Now, coming to the what are the disease correlates, I think after we discussed about the kinds of body fat which are distributed, we all understand that the obesity is linked to insulin resistance, metabolic syndrome, and all its components, and which finally obviously can lead on to various end organ diseases, predominantly the cardiovascular diseases. We as hepatologists, we understand about the fatty liver disease, and then the obstructive sleep apnea and various kinds of malignancies. So briefly, I'll just go over how these diseases or disease correlates are there with the kind of obesity and the body fat distribution. So now the first question which comes to our mind is, we've talked about the subcutaneous adipose tissue, we have spoken about the visceral adipose tissue. Now, are these both bad, and are these both causing insulin resistance and metabolic syndrome and its complication, or one is worse than the other? So overall, again, if you look at the literature, there are points favoring both visceral and the subcutaneous adipose tissue. They could be linked to insulin resistance, but the data favors more of visceral adipose tissue. That is linked more to insulin resistance, metabolic syndrome, and various complications. So why so? Because if you look at all patients, those who have obesity, every one of them do not have metabolic risk factors or metabolic complications, say of diabetes or cardiovascular disease and all. So some of them are, even though they are obese by, I think we will listen to the definitions of BMI and the other things, but some of them who are obese by the definition but could be so-called metabolic healthy. So they are known as metabolic healthy obese. So in them, what is there which is kind of protecting them from getting these all metabolic complications? So the literature says that there is probably difference in the body fat distribution in them. They probably have more of even though they are obese, probably they have more of subcutaneous adipose tissue which is grown up rather than the visceral. So this is a point which favors that visceral is more linked to the insulin resistance rather than the subcutaneous. Also, we know that metabolic abnormalities, including fatty liver disease, can happen in normal body weight. So these are known as metabolically obese but normal weight individuals. So again, the rationale or the reasoning behind this is that this is also dependent on overall body fat percentage, but also on the kind of body fat distribution. So these patients, those who are lean or those who have normal body weight, in them, if the visceral adipose tissue is more than the subcutaneous adipose tissue, I think they can still have all the metabolic abnormalities, and we know the pathogenesis of lean NASH and all that. So again, I think type of fat and the visceral adipose tissue comes in here, which is probably the culprit, even in normal, body weight individuals, contributing to insulin resistance and its complications. Also, there is data which is available that if somebody tends to gain weight, and if he tends to gain subcutaneous adipose tissue, I think the insulin resistance doesn't really increase, rather it can come down. But then if the visceral adipose tissue increases, then the odds of having or increasing insulin resistance goes up as high as 80%. So these are the points all favoring towards visceral adipose tissue as the culprit for insulin resistance and all its complications. But then if you look at the percentage wise, the kind of fat which is contributed by the visceral versus subcutaneous, I think subcutaneous tissue, adipose tissue, is much larger, and visceral fat is constituted only in men maybe around 15 to 20%, and women around 7 to 10%. So it's a small constituent of the overall fat. But then we are saying that this is more, responsible as a pathogenic fat. And even if you look at the free fatty acid flux, which happens because of the increased lipolysis, what we know which happens, in insulin resistance, again, only 15% is contributed by the visceral fat. So I think rest all is subcutaneous. So I think these are the points which are favoring that the subcutaneous adipose tissue also probably contribute towards insulin resistance, and it's not only the visceral adipose tissue, but as I said, the data is more in favor of visceral adipose tissue. Now, why? If visceral adipose tissue, if you are saying, is even though it is small, but it is contributing more towards insulin resistance, why is it so? Why is this happening? So again, there are certain, hypotheses for this, and I've just enumerated few of these here. I mean, the thinking is that the visceral adipose tissue, the fatty acids or the lipolysis which are released, the visceral adipose tissue is more liable to lipolysis or the release of more of fatty acids, which means that they are more sensitive to catecholamines for the release of fatty acids from visceral adipose tissue, and they are less sensitive to insulin. The job of insulin, we know, is to keep the fat in its place. So I think that is one. And also, the visceral adipose tissue is the omental fat and the mesenteric fat is drained directly by the portal vein, which goes into the liver. So, more of free fatty acids from there can get into the liver and can cause at least hepatic insulin resistance, which we will talk. And in general, again, the thinking is that the visceral adipose tissue is more metabolically active, which means not only because it has more of the adipocyte size is more in adipose tissue, in the visceral adipose tissue, but it is also more inflamed, which means a lot of inflammatory cells there. And this is again because of its proximity to the gut and the endotoxemia happening there and causing inflammatory cells to come in there. And also because of the larger size and the apoptosis and the necrosis of the adipocytes, which is happening, which is also, adding on to the inflammation there. So now once this is inflamed, I think the visceral adipose tissue is inflamed. This leads on to the consequences of insulin resistance and further. And I'll just show you how it does that. Finally, I think it has some relation with the, reduced adiponectin levels, which we will discuss, and also that probably this visceral adipose tissue is less responsive to the PPARs, which we know are, insulin sensitizing agents. Now, at the cellular level, what is happening? Which means that how the adipose tissue is, leading on to the insulin resistance. I think this figure very well summarizes this. And what it says is that once you have an adipose tissue, say visceral adipose tissue, which is inflamed, and there is lipolysis which is happening, so there's acids. So these free fatty acids can get into various insulin responsive tissues and can release or get converted into various lipotoxic, molecules like the diacylglycerols, ceramides, and various other things. So which by acting on, the further downward signaling like the protein kinase C can affect the insulin signaling, or these free fatty acids by acting through the TLR2 and TLR4 receptors through the NF-kappa beta pathway and the JNK pathway could also be affecting the insulin signaling. Also, because of this inflamed, adipose tissue, various cytokines are released, inflammatory cytokines, which are TNF-alpha, IL-1, IL-6. So they are all anti-insulin kind of, cytokines. And again, these cytokines through the NF-kappa beta and the JNK pathway will, affect the insulin signaling in the cellular level, causing insulin resistance, and simultaneously the adiponectin, is going down. So I think all this, as I said, at a cellular level, once you have an adipose tissue which is inflamed, I think ultimately is leading on to insulin resistance and various insulin responsive tissues. Now, what is happening in what kind of tissue once the insulin resistance there? I think three common sites, I think as hepatologists we understand. One is the white adipose tissue, which we have been talking, all these last 10, 12 minutes. As I said, we have not spoken about the brown adipose tissue here. So once you have the adipose tissue or the insulin resistance at the adipose tissue level, this causes more of lipolysis and the cycle of free fatty acid release, inflammation, insulin resistance at various levels goes on. But if the insulin resistance is happening at different other levels, for example, in liver, we know, and if there are, the lipotoxic molecules come in there, and we know they can cause fatty liver and NASH. Also, the hepatic insulin resistance, we know, is also responsible for increased production of, glucose by, increased gluconeogenesis and more of glycogenolysis, and that leads on to, hyperglycemia. And further, we know that the various growth factors can cause the beta cell hyperplasia in the pancreas, leading on to hyperinsulinemia, which also we know is lipogenic. At the skeletal muscle level, the muscles play a major role in taking up the glucose and the lipids. But then if the insulin resistance is happening at the skeletal muscle level, there's a reduced uptake of glucose by the muscle, which again further leads on to more of hyperglycemia and all its consequences. And similarly, at various other organs, pancreas, as I said, it can lead on to hyperinsulinemia and ultimately diabetes. But important is the vascular endothelium, which is responsible for hypertension and various cardiovascular outcomes. And this is because that insulin, we know, it is basically causes vasodilatation through the nitric oxide, and whenever you have the insulin resistance, there is vasoconstriction which happens at the vascular endothelial levels, and the kind of dyslipidemia which happens in insulin resistance, where the small LDL it goes up, small HDL goes up, they all are responsible for various vascular complications, and then I think at kidney and CNS level things can happen. So let me just now finish by my last two slides by showing on the fatty liver as hepatologist. I think again a lot of data about the kind of fat distribution which happens and has been linked with fatty liver. And this was one study from Abhijit's group, I think around 10 years back, where they had shown that even in lean people, those who are lean in comparison to their healthy controls, I think the overall fat percentage was higher in them, right? And overall insulin resistance was higher even in lean. So they said that overall fat percentage is higher, they are more of insulin resistant, even though their body weight as per the BMI was not high. We did this study again around 8-10 years back, and that time Narendra was with us in the department. And again, I think Dr. Praveen is going to talk about the various ways to measure with different kinds of fat. But this is the plain CT which we had done at L4, L5 level, and this was the subcutaneous adipose tissue. This was the visceral adipose tissue, and we tried to correlate all this with the severity of NAFLD, and we found that the both are probably related to the severity of fatty liver disease. But one interesting finding which we found was that when we corrected the visceral adipose tissue for BMI and looked at the differences between the lean and the overweight people, there was no difference in the visceral adipose tissue in them. So again, thereby saying that even if you are lean, but these people probably have more of visceral adiposity, which is probably responsible for more of insulin resistance and all the consequences, including fatty liver disease in these lean people. And this is one recent study which I have picked up, published only 3 months back, where what they did was that they took 40 obese people who underwent bariatric surgery. So they took mental biopsies in these patients, And they looked at, they did the immunohistochemistry and the mRNA expression, and what they found was that the patients, those who had NAFLD, in their visceral adipose tissue, which is the mental biopsy which they took, it was much more inflamed with macrophages, lot of microvascular density, and lot of expression of the hypoxia, apoptosis, and inflammation, which is again, as I said, contributing towards causing the inflammation of the visceral adipose tissue, and in causing the fatty liver disease. Not only in causing the fatty liver disease, but also causing the severity of hepatic injury, which is they correlated with steatosis, inflammation, and with fibrosis. So again, I think putting more money on the visceral adipose tissue as the culprit. So let me summarize, ladies and gentlemen, which I said in last 15 minutes or so, that obesity, we know, is when we talk about obesity, we mean that there's an excessive growth of adipose tissue, and this can happen both in the subcutaneous adipose tissue and the visceral adipose tissue. Now, what determines that what kind of body fat distribution a person is going to have would be dependent on various factors. And the important one are your age, your gender, your ethnicity, and the kind of nutrition. I told you about the VAT prioritization hypothesis. If there's a fetal, undernutrition versus the overnutrition with saturated fats and the high sugars and the gut microbiota, which could all be contributing to the kind of fat. Finally, if somebody is obese, we know that the clinical correlate would be that the fat tends to get, inflamed and causes a chronic inflammatory state, which is responsible for insulin resistance, metabolic syndrome, and all its consequences, including cardiovascular disease and the fatty liver disease. Overall, if you look at the data, there's more data which favors the pathogenic role of visceral adipose tissue over subcutaneous adipose tissue for causing insulin resistance and all its clinical correlates. So thank you very much for your kind attention, and let me stop sharing my screen here.
Thank you, Ajay. That was a brilliant talk. Dr. Ajay has told us that visceral adipose tissue is more important because it is more prone to lipolysis, more inflammation is there, and it also leads to insulin resistance and contributes towards excessive fatty acid input to the liver, causing non-alcoholic fatty liver disease. We'll have the questions in the end of the symposium, and therefore now it is my pleasure to invite Dr. Praveen Sharma. He's the Senior Consultant Gastroenterologist and a brilliant academician and very good speaker. He's going to speak on the assessment of body fat, what are the methods and what are the practical methods and what are the research methods. Dr. Praveen Sharma.
Thank you, sir. And first of all, thank you, Dr. Ajay, for such a wonderful talk. And he told us why one should know about the amount of fat in our body and the distribution of fat in our body and how it is important to know. So I will be covering my talk on assessment of body fat. So before I say, there is no single assessment method that allows measurement of fat in all tissues and organs, and there is no method which is error-free. So whatever method we have, they have some sort of error, but the things are going on and we have good methods to assess fat. Dr. Ajay has already told that in human body, the body fat can be divided into brown fat, white fat, and the beige fat. The white fat can be ectopic, which could be in the liver, in the myocardium, in the muscles, in the pancreatic, and in the visceral, we have intraperitoneal, retroperitoneal, and the subcutaneous, we have abdominal subcutaneous fat, femoral subcutaneous fat, gluteal subcutaneous fat. So to assess fat, which contribute both by the brown fat, the white fat, and the beige fat by a single modality is very difficult. So we have different methods with us. So first of all, the types of fat which we have in our body, it is divided into three types: the brown fat, which is rich in mitochondria and looks brown; the beige fat, which is intermediate between the white fat and the brown fat; and the white fat, which we are talking about, that it can be into the visceral or the subcutaneous. But for the obesity treatment, now the theory has now been changing. It is now hypothesized that somehow we can change our white fat into the brown fat, so obesity can be overcome. But it is a difficult area and the research is going on. But the assessment method for the assessment of brown adipose sites are also going on. So what are the different types of method which we have? We have methods which are based on anthropometry. We have methods which are based on density methods like underwater and air displacement plethysmography, conductivity based method like bioelectrical impedance, the DEXA, and the imaging like CT scan, MRI, and the PET scan. So I will go by one. So how do we assess body composition? Our body can be divided into 4 compartments. So we have 2C model, 3C model, and the 4C model. So most of the tests which are there for the assessment of body fats are divided into these models. So our body can be divided into body fat mass and the fat-free mass. If we can go above it, then the fat-free mass can further be divided into the lean tissue mass and the bone mass. And the lean tissue mass can be further divided into proteins and the total body water. So we have 4 compartment models, which is a combination method. We have 3 combination models, which are like DEXA, bioelectrical impedance, and the CT and the MRI, and the density method, which are underwater and the air displacement method. First of all, we see why do we need to go for so much of advanced tests for the assessment of fat, though we have anthropometric tests which are well validated over the years for the complications of obesity. The first and the foremost is the body mass index, which is weight in kg divided by height in meter squares. Though it is very simple, easily measured, population based, and it has been shown to associate it with other risk factors, the complications of obesity. But why it is so not being used? First of all, we have different demographic status. In the Western countries, we have definition of obesity is different, and in the Indian population or the Asian population, the definition of obesity is different. So it depends upon the BMI, depends upon the geographical area and the ethnicity of the people. And it is not a direct measurement of fat. If people can have a same BMI, but he can be obese, he may not be obese, that he may be muscular. And the BMI vary in extremes of age. For the smaller children and for the adult group who are more than 70 years, fat distribution is not assessed. BMI cannot distribute whether the patient has more of subcutaneous fat or more of visceral fat or more of fat in the organs. And it cannot differentiate muscle and fat. So BMI is not a good method to assessment of fat in our body. Then we have the waist circumference. Waist circumference also is being used for many population studies for the assessment and its relation with the metabolic syndromes and cardiovascular risk factors, but it has got its own limitations. According to WHO, waist circumference should be monitored midway between the last rib and the iliac crest. According to national consensus, the umbilicus level should be used, and the tape should be held not snug, but it should not be compressing the skin. And patient who have the people who are male, they should have low risk if it is less than 40 inches, and the female it is less than 35 inches. But again, it is an indirect measurement of fat. Distribution of fat is not measured. It cannot differentiate between the subcutaneous, the visceral, and the brown fat. And also measurement between people to people is different. So it is not a good test to assessment of fat. Then we have the waist to hip ratio, in which the waist and the hip ratio is, the hip girth is measured and the ratio is being taken out. So anybody, it can be, it again assesses the fat, but not the distribution of fat can be assessed, whether it is more of the abdominal or more of the girth muscle. So according to that, waist and hip ratio is now considered as one of the best predictors for the complications of cardiovascular disease, diabetes prediction, insulin resistance, and it has been shown that it also predicts more with the DEXA and MRI. So waist hip ratio is now considered as one of the best anthropometric measurement for the assessment of fat in our body. But it cannot differentiate between subcutaneous, visceral, and the organs, and about the brown and the white adipose tissue. This is a landmark study, the IDEA study, which has shown that anybody whose waist circumference is more than 99 has more prediction for the CVD and for the diabetes. So if we can make out by doing a simple waist assessment, why do we need more sophisticated tests? Because the concept of obesity is now being changed. Skin fold thickness is also being used, but it is still cumbersome, does not differentiate between the subcutaneous and the visceral fat, and various measurement equations are used to validate its efficacy over CT and MRI. Then we have the 2-compartment model, that is a hydrostatic or the underwater weighing. It is based on the Archimedes principle that underwater weighing is based on the fact that the lean body tissue is more dense than the fat. The calculations are based on some parameters, and the person is submerged repeatedly underwater 8 to 10 times to calculate the body fat. To overcome this underwater, there is another test which has been used, which is commonly known by the name of board port, in which the person is sitting into a cabin which is filled of air, and the same principle of Archimedes is being used, and the patient weight and his fat content is estimated. So underwater, the patient goes into the water, the weight is being taken outside and inside, and similarly in the board port, the patient sits into the chamber and his weight is taken out. This is how a board port reading looks like. It can tell us whether how much percentage of fat is there, that this patient had 10.6%, how much is fat-free mass, how much is the body mass, total weight, the total body volume, and the body density. This is how it looks like. But it can only tell us how much fat is there in the body. What are the disadvantages of this? It is cumbersome method. It requires a large space, repeated measurement and not acceptable to many patients to go into the water and into the cabin. And it only assesses the fat and the fat-free mass. Location of the fat, distribution of the fat is not assessed by these two methods. So we have some more sophisticated methods, which are the DEXA. It is based on the principle of giving two X-rays of different variations to the body, and normally we use DEXA for the bone, but it can also be used for the assessment of fat in our whole of the body. It is also an indirect method of fat estimation, and X-ray exposures are required, so repeated measurements is a problem for this method. This is how the DEXA machine looks like. The patient should lie still for about 15 to 20 minutes because the scan takes about 20 minutes. If the patient moves or patient has some spinal deformity, then this method is normally not used because it is not predictive. So the two X-rays are given to the patient, and the patient moves the whole body, and we can have the assessment for the body fat as well as for the bone. This is how we can estimate for the DEXA. We can estimate the bone, we can estimate the fat, and we can estimate the fat-free mass. We can also estimate how much is the upper limb, how much is the lower limb, how much is the axial skeleton shows the fat quantity. So DEXA is slightly better. It is better than the other previous two methods because it can tell us where exactly is the fat in the upper bodies or in the lower body or in the abdomen. It cannot calculate normally the visceral fat directly, but we can calculate the visceral fat indirectly by taking the total fat and the subcutaneous fat. This is how a DEXA report looks like. If we go into the detail, we ask our person who is doing the DEXA to show the report. So we can calculate what is the amount of fat in the left upper arm, in the right arm, in the trunk, in the leg and the neck. So we can know about the fat mass in our whole of the body. And it has shown to be a good correlation with the other methods like CT scan and the MRI. There is an important study, the Dallas-Hurt study, which has shown that the visceral adipose tissue quantified by DEXA has shown over a calculation of about more than 1,000 people in both male and female to have good correlation with a MRI-based VAT detection. So people where DEXA, the centers where they have the facility of DEXA can calculate visceral fat and the subcutaneous fat where the MRI machine is not able to calculate that. Now we have different other methods like ultrasound method, though it is still under research, but by ultrasound, we can measure by two techniques. One is the triangle method and one is the ellipse method, the amount of fat in the subcutaneous and the visceral studies, but there are not much of data, but people are doing this for the because it is easily available and there is no exposure for the radiation. And this method has also shown to have good correlation of doing the visceral as well as subcutaneous fat compared to the CT scan. Now we have the imaging method, which is now considered as the gold standard. We have both the computed scan and as well as the MRI scan. In the computed scan, we do not require any contrast. It's a single slice method where most of the people they took either at L4, but there are studies that L2 and L3 is better than L4. So by CT scan, it is a program method. We can have the total skeleton muscle, that is, this is all red is total skeleton muscle, which we do for the sarcopenia assessment. We have for the visceral adipose tissue, that is the inner one, the yellow one. And we have the subcutaneous adipose tissue, that is this blue one. We can also calculate the intermuscular adipose tissue. So single scan can estimate fat at the different compartment level, both the subcutaneous and the visceral, and this is now one of the commonest methods used in most of the centers. Similarly, there are two methods. Either it is automatic by Slice-O-Matic program software, or sometimes it can be handmade. That is, we can correlate by just putting a cursor over the spinal muscles, paraspinal muscles, and over the subcutaneous, and we can calculate the subcutaneous as well as the visceral fat. Similarly, for the MRI, the same technique is being used, and it is radiation free. So, but the timing for the MRI is more, that it requires about 15 to 20 minutes. But for the CT scan, it requires hardly less than 5 minutes. But MRI is radiation free. So some people, they prefer MRI, but the correlation between the CT scan and the MRI for the detection of visceral, subcutaneous, total adipose tissue is almost matching. So we can use either of these two methods for the assessment of visceral and subcutaneous fat. Another method which is commonly used by most of the centers in hospitals also and in clinics is bioelectrical impedance analysis, which is very simple machine, handy. The patient just sit on the machine, and it has got it has the different electrodes based on 2 to 16, and the electric current passes from the one of the leg, and it goes into the other, and depending upon the how much is the soft tissue, how much is the bone, how much is the fat, one can calculate. So it has shown bioelectrical impedance has shown good correlation with the CT scan as well as with the MRI in most of the studies. So it's simple test which can calculate visceral as well as the subcutaneous tissue, but it cannot calculate the brown tissue. And bioelectrical impedance can also give us an idea how much is there in the axial, how much is there in the limb. So it can give a rough idea, and most of the studies which are going on correlate bioelectrical impedance with MRI and the CT scan. So, but there are some loopholes in the bioelectrical impedance also. It varies depending upon the electrodes used, it varies depending upon the machine used, and it depends upon the hydration of the patient. So depending upon the hydration, depending upon the machine, depending upon the electrodes, it calculates differently the visceral and the subcutaneous adipose tissue. So there are some drawbacks of this method also. Another simple method is near infrared entrance. In this method, there is a small probe which can be used in our clinic. It is a small probe which is put most of the time over the biceps, and it gives a reading of your fat mass. So it is there are not much of studies which have correlated this method over the CT scan and the MRI or the DEXA, but there are few studies which have shown that it gives a rough calculation of the fat and the amount of muscles in our body. So this is a method which can be used in the clinic, which is a method which is used by most of the sports people for their day-to-day routine activities. Now another thing which is now coming up, which is known as the estimation of the brown fat. The estimation of the brown fat is an upcoming concept that most of the methods like PET scan, MRI scan can detect brown fat, but the patient has to go a strict protocol. That the patient should be, the PET scan is done under a thermoneutral state, then the patient is exposed to a cold exposure up to about 15 degrees Celsius over a period of about 30, then the brown tissue get activated and it get picked up on the PET scan and on the MRI. So this is a method which is now considered as that one of the methods to reduce the obesity, is that we can convert the white fat into the brown fat so that it generates more of heat and the patient gets less obese over the period of time. So we have different methods for the assessment of brown fat, which is there by the PET scan or by the MRI. So new methods are now being coming up, but there are certain loopholes that the patient has to expose, that patient should be off some medications like any sedative medications, beta blockers, and most of the NSAID that should be off before doing this scan, and patient has to be subjected to a rigorous lower temperature for the assessment of this brown fat. So MRI can also be used. There are certain machines which are now being used for the estimation of brown fat itself. And to summarize, in the last, I just make a table that there is no single assessment method that allows measurement of fat in all the tissues and organs. And the anthropometric measurements, they are based on indirect method. They are simple. They are population based. They show good correlation with the metabolic syndrome, but they cannot distinguish fat from the muscle, from the bone, and the distribution of fat cannot be detected. Underwater or the board, they are also indirect method based on the density, They are most used to the direct assessment of method, but still they are cumbersome. Availability is a problem. Patient has to keep his clothes off. That is a problem for most of the patient. Space is a problem. Type of the fat cannot be detected. Then we have the DEXA, which is now considered as the method of choice for maybe most of the children. In most of the studies has shown that DEXA is better than the CT and the MRI for the assessment of the fat. So it is based on the assessment of density of the tissue by using 2 X-ray beams. It is considered as one of the gold standard for the pediatric group, but it is also easily available. But radiation exposure is a problem. Obesity is a problem. Patient with different machine have different problems. Spinal deformity. Patient need to lie straight and no movement for about 20 minutes. That is a problem. Bioelectrical impedance, it is based on the impedance method, easily inexpensive, can be used in our clinics for the assessment of fat as well as for the assessment of visceral and subcutaneous things. But it underestimates fat as compared to the CT and the MRI, and the different electrodes and the different machines can have different values. CT and the MRI, they are based on tissue density. They are easily available in most of the centers. Radiation is a problem. If the patient is very obese, then sometimes it's a problem. Different machines and different programs can have slightly different values. That is a disadvantage in that. In the MRI, if patient is super obese, cannot go into the MRI because the MRI machine itself is not meant for that much of obese people. But it is a single most important test who can detect the whole body fat assessment in the single go. Time is a problem because it will take about 30 minutes. Then the PET scan and the MRI scan for the assessment of brown fat, but the patient has to undergo a cold exposure. Methods are not much reliable. They are still under protocol, and there are limited human studies for the assessment of fat in this type of by methods. Thank you.
Thank you, Praveen. That was a brilliant description of the assessment methods. And in short, you've told us that CT is possibly the method of choice today, convenience as well as many other factors, while the DEXA, if it is available, can also be used.
Used for that.
We will now move on to the last talk, and I'll request Dr. Chawla to introduce the speaker.
Thank you, Dr. Anand. It's a privilege for me to introduce Professor Anup Mishra, who is very well known in the national and international circle of diabetes, obesity, and hepatology and gastroenterology. He's a product of All India Institute. We used to work together many, many years ago. But he's also a Padma Shri recipient, also a BC Roy awardee. So he has a lot of publications to his credit, and he's been the chairman of the Fortis Center for Diabetes and Obesity, and also a chairman of the National Diabetes and Obesity Party of India, Government of India. So he's into the policy decisions of a lot of conditions related to diabetes and obesity. And let's listen to the giant today, Anup Mishra.
Thank you, Yogesh. It's indeed a pleasure to be speaking among the giants of hepatology and also body fat and obesity. Others have spoken most of the things. My job is simpler and there may be some repetition, but I'll limit my presentation mostly to Indian population. That's where our focus has been for the last 20 years since we started the studies in obesity in the United States. I will also clear some doubts because some terms have been used repeatedly by most of the top people in the world, and which are not entirely correct, and I'll just a couple of clarifications also needed. Now, a background: rising obesity prevalence is one of the most serious health challenges facing the world today. In India, obesity is emerging as an important health problem, paradoxically coexisting with significant number of undernutrition prevailing under different sections of the population. The prevalence of obesity is particularly high in urban population, and the Indian population is showing a rising trend of obesity both in children as well as the adults. about 30 to 65% of adults, according to one estimate, in Delhi are either overweight or obese. Now, if you look at, just before proceeding any further, if you look at the body composition, and everybody has been talking about body composition, and let me just clarify a couple of things. Everybody knows that the fat-free mass is 80% of the body. And amongst them, the body protein is 13%. So, and fat mass is 20%. Now, if we extrapolate it to a 70 kg human subject, then how much would be the fat in the body? 14 kilograms. Now, if 14 kilograms is further, divided into the subcutaneous and the visceral or so-called visceral fat, then it will be 4 kg versus 10 kg. 10 kg will be the subcutaneous fat. So you see the weight of the subcutaneous fat is far more, 3 times more than the intra-abdominal, thoracic, and pelvic visceral fat. And everybody says my muscles are too much and things like that. The muscles are only 9 kg. They can be increased in size also. Now, the second thing is about called visceral fat. Now, this is the this is the seminal publication. Anybody who wants to read about body composition, this is the publication. This is in 2003, but I don't think anybody has surpassed this particular publication. This is total adipose tissue, and the various compartments of visceral adipose tissue. This is interesting because everybody thinks that abdominal is the visceral adipose. It is not. It is the thoracic visceral tissue, it is abdominal visceral tissue, and it is pelvic visceral tissue. So once we talk about so-called VAT, it is an incorrect term, and it encompasses all then visceral tissues. So if you want to specifically say about abdominal, then you say intra-abdominal visceral tissue or intra-abdominal adipose tissue. Now, obesity in South Asia, there are a number of publications that we have on this issue. This is one of the recent publications, and you can see that abdominal obesity by several, including Chandigarh here, several publications, abdominal or general obesity prevalence is listed here. The general obesity 11 to 30% and abdominal obesity 18 to 36%. But the national surveys tell otherwise. Look at the national survey. National Nutrition Monitoring Urban Survey of 2017. These are various states. And this is the men and women prevalence of obesity. Look at the very, very high prevalence of obesity in New Delhi, Tamil Nadu, Pondicherry, Gujarat, Kerala, up to 50%. And this is the national survey. Look at that. And especially in women. So women surpass 1.5 times more obesity in women. And so are related metabolic syndrome problems in women. Now, which measure of obesity we have already talked about. Just to go through it again, body mass index, waist circumference, waist hip circumference ratio. It is not waist hip ratio, it is waist hip circumference ratio. Waist height ratio, body fat, sagittal abdominal diameter, CT, MRI defined abdominal fat or any other fat, and a body shape index. This is a recent publication on this new method. This is BMJ Open, a body shape index. And moreover, as far as body mass index is concerned, that, we freely use this formula of kg by meter square from the Western population, where it has been proven that this formula is correct. Kg by meter square, this ratio is correct. India, nobody had proven in Indian population. Till publication here, which on which we wrote editorial with Nikhil Dhurandhar, that the current formula of calculating body mass index is actually applicable to Indian population. And there was huge amount of data the authors used to see that this kg per meter square is correct for Indian population. We have a number of publications. Otherwise, we are proud to say that in a symptometric assessment of obesity research from 2007, the year I left All India Institute of Medical Sciences, to 2016, we are at the top as far as publication is concerned, ahead of most of the government institutions and other groups. And we continue to publish in COVID-19. Look at the publication at the down. We have a number of publications on obesity and COVID-19. Now, in 2008, there till then there were a number of debates. In 2003, I debated in International Conference of Obesity whether the body mass index, which is the cutoffs which are applicable for international populations, everybody, is actually applicable for Indian population. And I debated against June Stevens, who was a very top researcher from Kentucky at that time. And this was published in the International Journal of Obesity. Then 2008, we gathered a number of renowned researchers from India, and we asked a couple of questions. We certainly wanted that interventions to reduce obesity are needed in Indian population, and especially because Indian population developed diabetes and metabolic syndrome at a lower level of obesity, and that diagnosis of obesity should be earlier or at lower level than the Western, the cutoffs which are defined for Western population. And WHO was dithering, and we have also published dithering of WHO on this, that they say, oh, a country can take a decision, and there's a Asia Pacific region, some definitions and things like that. So the WHO till now has not been clear on this issue as far as BMI cutoffs are concerned. And we calculate that if decrease BMI limit from 25 to 23, nearly 15% of the adult population of India, which means 5 to 7 crore people, will benefit because the interventions will be earlier in them, and some may not develop diabetes or other comorbid diseases. So overall benefit to the population would be immense on the long term. Now, we gathered a whole lot of studies, including several of our Indian studies. First three are Indian studies, and then there is a Dr. Bhansali studies. In fact, most of the studies are ours at that point of time. And this is one way to define obesity. You look at the body fat, and then you look at the BMI, you have ROC curve, and look at the optimum BMI level to define a particular percentage of body fat. And we define at this, most of the studies define 23 as the optimal level. We also looked at, we and others, Snehata Ramchandra group, we also looked at whether a particular limit of BMI will indicate cardiovascular risk or diabetes risk. And you can see about 23 BMI, the diabetes risk is increasing. This is published in Diabetes Care, Snehata and Ramachandra's group, and our group in the International Journal of Obesity, more than 23, increasing the risk for at least one cardiovascular risk factor. This is Naval Vikram, myself, and others. But then subsequently, recent times, there is a resurgence of interest in the nations which were not taking interest earlier, for example, UK and USA. So in 2008, when we fixed the criteria for obesity, lowered the criteria for obesity in Indian population, then UK in 2015 did the similar thing for the for migrant Asian population. US had no move. But there are a number of studies which are appearing. Look at this particular study where 5 ethnic groups, including South Asians, have been compared, and their metabolic abnormalities phenotype has been seen. Now look at this where I've outlined in the yellow. These are the normal weight people, and Indians have highest rate of metabolic abnormality, though they are normal weight. Dr. D'Souza was saying the similar thing. And cutoff for BMI for having increased risk for metabolic abnormality, similar to our previous experiment where we looked at the cardiovascular risk factor, was 19.6 for South Asian population. So only below 19.6 that the South Asians have no or better metabolic risk profile. This is Annals of Internal Medicine, Dr. Gujral, who's my colleague, his work, and Alka Kananian's group. Then subsequently, number of other groups. Look at this: BMI and risk for type 2 diabetes in South Asian, Chinese, and blacks in USA. And this is incidence, depending on the incidence of diabetes. And look at the South Asian, similar findings in 2008 that we determined, as was determined in 2016 here. South Asians 24, Chinese 25, black 26. And subsequent to that, American Diabetic Association lowered the criteria for checking for diabetes. not BMI criteria for obesity, but for checking for diabetes as 23 for all Asian population. Now, remember, any research when we are saying Asian, it means a whole lot of groups. It does not mean South Asian. Here is the South Asian population, but number of other research has been done for Asian population. So they fix for all Asian population. There are 60 types of Asian population. Now, previous to that, we also worked on the MRI using MRI and DEXA scan, multiple measures of obesity, and using more than one cardiovascular risk factor. We looked at what is the optimum cutoff for body fat. And look at this, 25% for men, which is similar to the Western population. Some of the people have worked on this, and women, 38%, 30 to 35 to 40% are various cutoffs in the Western population. We also looked at a fat trunk percentage cutoff and total lean mass cutoff, which is also given here. This was published in 2011. Now, coming to the waist circumference. Measurement of waist circumference was referred to in the earlier presentation. And those of you who are interested in management of obesity in adults, this is our very good publication in Indian Heart Journal. And this is the diagram which has been given. Waist circumference is subject should be fasting state, number one. Standing erect. Observer should be sitting in the front of the subject. Waist circumference is measured with non-stretchable, flexible tape in horizontal position, just above the iliac crest at the end of normal expiration. So patient should take 1 or 2 breaths and then normal expiration. This is the correct way of taking. Of course, there are other ways also where the lower angle of rape than anti-reciprocate is fine. In between that, it has, but that's a little difficult, and this is the easiest and the best method. Now, what about the waist circumference? 102 and 88 for males and females was the international criteria for waist circumference. And we looked at this and published in 2005, and then subsequently a spate of publications, and subsequently hue and cry in the international community that in South Asians or say Asians, the waist circumference criteria should be lower. Now look at this, in males, in 90 centimeter, the cardiovascular risk, at least one risk factor, the odds ratio was 9.6. And so we thought that 90 is the correct waist circumference cutoff for Indian males. And similarly for females, 80 centimeters. So these were some of the first publications, and subsequently this has been very well accepted. Unlike the BMI, the waist circumference has been very well accepted, and most of the definitions of metabolic syndrome now use this waist circumference for South Asian population. Now, similar findings were shown by Dr. Ramachandra's group, 80 to 90 centimeters as the cutoff for males and females. And so this was the summary at that time when we looked at the revision of criteria and fixed at 90 and 80 centimeters. Now, a couple of slides about this subcutaneous versus intra-abdominal fat controversy as far as South Asian is concerned. I have already told you the mass of the subcutaneous fat is far too high. So anything, even a small bit of free fatty acid which is coming out of the subcutaneous fat is far overshadows intra-abdominal fat. But even look at this, in South Asians, it is intra-abdominal fat perhaps is not high than the white people. It is the subcutaneous fat which is high. Look at this. This is a very good publication by Lear, who have been working in obesity from UK. And look at this. The BMI matched population, waist circumference almost matched population, but body fat far too high in South Asians. But look at total abdominal adipose tissue area. The total abdominal adipose tissue area is almost 100 high than Chinese and 50 high than European. And subcutaneous fat, look at this, 265 here, 221 here, 309. And visceral adipose tissue intra-abdominal, 100, 100, 150, not much of difference. It's statistically significant, but not much of difference. So it is the subcutaneous fat which is thick, very thick. And this has been shown by Abate's group from UT Southwestern, that if you look at the calipers, the subcutaneous fat measurement with the calipers, in the subscapular area and the suprailiac area, we will have double the amount of subcutaneous fat. So truncal subcutaneous fat is far too high in South Asian population. And we subsequently published that it is the subcutaneous fat which is correlated with metabolic syndrome, not intra-abdominal fat in our population, and using multiple statistical modeling. We have published a number of studies on various types of fat and differences from white population. This is the 2018 publication, and I'm not going to details about hepatic, etc., thigh subcutaneous fat and skeletal muscle lipids and subcutaneous adipocytes and things like that. But one thing which needs attention here is the deep subcutaneous fat. Now, this was referred to by Dr. Zuseja. This is one of our publication, and the MRI at lumbar vertebra 3 and 4 has been taken from the publication. Now, look at the fascia here. In the subcutaneous fat, there is a fascia here, and this is superficial and this is deep. There is a great relevance to deep subcutaneous tissue, which is posteriorly located. Look at the software delineating posterior subcutaneous tissue, deep subcutaneous tissue. The cells are different. The metabolism of this deep subcutaneous tissue is different. And I have a number of slides, but I'm not going to show you that. But just to suffice that this is a different kind of fat. And if you go down from lumbar vertebra 1 to lumbar vertebra 5, which we did in this very good publication 1997 from UT Southwestern at Dallas, the subcutaneous tissue mass increases by twofold. And this is predominantly because of posterior subcutaneous tissue, which on hyperinsulinic euglycemic clamp, which we did at that time, is highly correlated with insulin resistance. It was not superficial, not intra-abdominal. We further here looked at the using an MRI study in the non-obese patient with diabetes and matched controls, non-diabetic controls. We found that the moment, and these are newly diagnosed diabetic patients, the moment they become diabetic, if you look at their total abdominal fat, intra-abdominal fat, they're far too high than non-diabetic controls, BMI matched. And liver span is also, this is a PLOS One publication we did some time back. As far as the brown adipose tissue is concerned, we have talked about how to measure brown adipose tissue, but there's a difference of brown adipose tissue in South Asian population. Look at this, total BAT volume of South Asian, this is a UK study, was far too less than white. That means non-shivering thermogenesis was increased in white and not in South Asian, and resting energy expenditure was far too low. So sitting, we are at metabolic disadvantage. So both people are sitting, South Asian and white Caucasian, they are spending more money, more energy because of the brown adipose tissue. So this is the diagram that was pushed by my colleague from UK, that in people who are not going to be having much of metabolic abnormalities in the blood and otherwise because of multiple factors, if we take energy, too much of energy, in the most of the energy is deposited in superficial subcutaneous tissue and the site hyperplasia. Now this doesn't produce so much of free fatty acids, so liver is protected and there's no change in the cardiovascular, cardiometabolic risk factors. However, in people who are predisposed like we are, then there is a hypertrophy of deep subcutaneous adipose tissue, which has a greater propensity to throw out free fatty acids, and then liver, heart, everything is affected. So we, in 2000, coming back to the story, we fixed the MRI for the BMI definition for overweight as 23 and obese as 25, as opposed to 25 and 30. But the story, as has been mentioned earlier, does not end here. And recently, there have been a lot of opposition to BMI as a criteria for obesity, like my friend from Canada, Arya Sharma, Canadian obesity chiefs, they have put a different version of diagnosis and management of obesity recently. Now they say caveat for BMI. BMI is not direct measure of body fat, does not indicate body fat distribution, does not amount to muscle mass, can underestimate body fat in people who have lost muscle like sarcopenic obesity, does not distinguish between men, women, and ethnicity, is less accurate in certain population like South Asian, and so number of problems as far as BMI is concerned. Now waist circumference, the action level 2 and the action level 1 have been fixed in this 2008 document, 1980 centimeter for men and women for diagnosis of abdominal obesity and waist hip ratio. But then there are number of caveats for waist circumference too. Is not direct measure of visceral fat, intra-abdominal visceral fat. Considerable training and standardization are required to ensure intra-reader reproducibility of waist circumference. Is sensitive to abdominal distension due to fluid intake, bloating, ascites, pregnancy, varying cutoff for ethnic populations, less sensitive measure of intra-abdominal visceral fat with increasing BMI, and waist circumference requires further body exposure and can be perceived as intrusive measurement by some patients. So number of problems. Now this is the various cutoff in the same document, 2009 document, treatment of obesity. We lowered the cutoff for initiation of pharmacotherapy and also bariatric surgery. Almost similar cutoffs 10 years later are going on. So nobody has changed any cutoffs here. Now final slide is the Edmonton Obesity Staging System by my friend Arya Sharma. And this says that according to disability due to obesity, you fix the treatment, intensity of treatment for obesity. And so there is 0, 1, 2, 3, 4 stages depending on disability, and your treatment also varies. So this is some sort of a new concept, not that it is something which was not known to us, and that not that we did not look at cardiovascular risk and others did not look at cardiovascular risk, the increasing obesity, so that's a disability itself. But this is more defined now, and so everybody is talking about so-called new way to look at obesity, not much of a stigma, look at the associated comorbidities and treat accordingly and so on. And there are a number of components for assessment of obesity. I'm not going to details. This is available on Canadian Obesity website. So with that, I finish my presentation and I'll be happy to take any questions.
Thank you, Anup, for an excellent talk and taking us through changing our concepts to a little extent. You were instrumental in bringing down the level of BMI for the Indians. You've also been instrumental in decreasing the level of waist circumference as responsibility for metabolic syndrome. And something new, which at least I gathered, was that subcutaneous intra-abdominal fat is more important than the visceral fat, and that also the posterior subcutaneous fat has more associations with insulin resistance. So thank you, Anup. We could have some questions for the speakers, and I invite the questions. Can we go to the Q&A? Anup, there's a question. How can we change white fat to brown fat in adults?
Okay, I think that's a very, very important question, and I have a full lecture on the white fat conversion to brown fat, and in between there is a the beach fat, which is the intermediate type of fat. So good amount of exercise itself, increase in the catecholamine level, and drugs, in fact, the beta stimulant drugs have been shown to convert the white to brown fat. And there are certain amount of food, and it'll be interesting, Yogesh, to know that the chilies, mirch, capsaicin has been shown to convert the white fat to brown fat. And similarly, the peel of apple peel has a certain substance. I'm forgetting the name at this point of time. I have a couple of slides of that. That also can convert. So this is in fact, the most intense area of research, how to convert white to brown so that the non-shivering thermogenesis increases and resting energy expenditure increases, and that will be thinner with the similar amount of exercise that we were doing previously. We'll lose probably more weight.
Anup, you didn't talk about sarcopenic obesity. You just brushed aside. Can you tell us about sarcopenic obesity in short?
I actually right, but that's a full lecture which I gave 3 days back to Mumbai audience. Uh, Sarcopenic obesity is actually, if you look at the sarcopenia first, then a large majority of Indian population has sarcopenia. And I'm not going to various ways of measurement of sarcopenia, but if you look at the hand grip strength by Jamar dynamometer, then around 60 to 70% of females and 50% of the males around 50 years of age will have sarcopenia here in India. Now, as the age goes on, the muscle mass, function, and a capacity to metabolize glucose goes down. So muscle goes down, and there is this distribution of fat. Now, with age, the ectopic fat will increase and subcutaneous fat will decrease. So there is a decrease of pre-adipocytes in the subcutaneous fat, and there pre-adipocytes are the ones which actually store fat. So once they go down, the capacity to store fat in the subcutaneous adipocyte goes down, and the fat is stored in the liver, like Dr. Juseja was saying, at various ectopic organs. So there is increase in the body fat, decrease in the muscle mass, BMI may remain the same. Hence, measurement of both here is important. Measurement of muscle function and muscle mass, and measurement of body fat, BMI may be fallacious. Now, some people say that if BMI is more than 30 and various definition of sarcopenia say that the muscle mass is less, then you have sarcopenic obesity. No cutoff for sarcopenic obesity in terms of muscle mass has been fixed for Indian population, but there is an Asia-specific definition which is available, which I often show in my presentation. Most of the people above 70 years in India will have sarcopenic obesity.
So thank you, Anup. AC, yeah, you can
one or two
ask some.
questions from the audience which has come. One is from Dr. Kathakali. I think she asks why some people never gain weight even if they eat more, and why some people gain weight even if they eat less.
I think Dr. Juseja will be able to answer that.
I think it's a difficult question, I would say, but then I mean, I agree with the observation, and we do see that, but probably I think it's the multiple factors which are responsible in a particular individual in gaining weight or not gaining weight. It's not only the nutrition. Obviously, I think the imbalance of the calorie, the amount of calories somebody is taking, the physical activity somebody is doing. Then, as I said, the role of gut microbiota would come in, and the role of genes would also come in. So I think a lot of this multiple factors would be responsible in somebody gaining weight and the kind of adiposity somebody is having, and it's not dependent on a single factor. So I think multiple factors, I would say, would be involved in that.
Then Dr. Sundar Das Dudeja has asked, what is the impact of late night eating which is responsible for obesity and large stomach? That means eating breakfast more is more beneficial in preventing obesity, or eating late night leads to more obesity?
I can answer a bit about the breakfast. There have been a huge amount of controversy whether the eating the correct breakfast will actually lead to lesser obesity versus leaving breakfast and will lead to weight loss. Most of the studies now indicate that if we have a balanced breakfast, which includes more of a protein, more of a fiber, uh, right in the morning, and look at their versus those people who are not eating breakfast and look at their long-term weight, there is hardly any difference between the two. So actually leaving breakfast does not do one any good, though that's one thing sure. Whether longer term study will show that eating right amount of breakfast will ultimately lead to weight loss will depend on number of other factors. As Dr. Duseja said, physical activity, the composition of other meal, composition of his body, and presence of brown fat and things like that. As far as the late dinner is concerned, it has some impact on the hepatic glucose output and early morning hyperglycemia. That I can say. As far as the weight loss is concerned, I have not come across any very good study to see whether it causes a weight gain or weight loss.
Can I answer, Dr. Anand, that partly?
Sure.
Yeah, you see, there is a basic concept of circadian rhythm, which we tend to ignore in maintenance of the body weight, which clearly states brain by default, because of the signals, which could be visual, which could be time related, which will perceive late evening as the resting state. If that is the time when you tend to overeat and have a heavy late night dinner, then your whole process goes haywire. Because at the level of the neurochemistry within the brain, the centers which determine your resting energy, centers which determine your appetite, certainly will not respond to the late night dinner, because at that time the brain is perceiving it is a ratio between the leptin and adiponectin, which is to be decided by the hypothalamus and the appetite suppressing and stimulating center. So it is obviously bad to have a late night dinner. There is a big role of circadian rhythm which has not been well studied.
Skipping breakfast is now called as in fashion these days because of intermittent fasting. So, what is your thinking about it?
Sorry, are you asking me?
Asking
Anyone
whom?
can answer? It's an open question.
Okay, sir, it's like this. Um, there are a number of studies on intermittent fasting, and I'm only talking about the patients who have diabetes more often, and some patients who are non-diabetes, don't have diabetes, normal people. Now, the most of the studies are not robust enough. However, some studies show that there is a definite weight loss and there is decrease in inflammation parameters. But a recent meta-analysis, which was done in 2019, looked at all studies which were uh, in employing intermittent fasting versus all studies which had the restrictive eating only, not time restrictive eating. Time restrictive eating is intermittent fasting. Restrictive means just calorie decrease in the calorie and usual meal. There is no difference between the two as far as weight loss is concerned. A recent randomized trial in JAMA Internal Medicine between time restricted eating and the usual eating with some calorie restriction show that there is no difference. In fact, in those with intermittent fasting lost lean mass. So there is a problem here. So intermittent fasting may lead to long-term decrease in the lean mass, also osteoporosis, and may not be different as far as weight loss is concerned to a calorie restrictive usual diet that we do.
Dr. Anand, can I answer again partly?
Sure, why not?
You see, there is in the first webinar on obesity about last month, we did discuss this issue at length. And I think there was a very good, clear consensus that what matters, as Dr. Anup very rightly said, is the total calories you consume, irrespective of the nature of the diet, timing of the diet, pattern of the diet, type of the food. What matters is the total calories, and calories are calories. In fact, there is a dark side to intermittent fasting. It is believed that if you have been intermittently fasting, at the time when you're not fasting, you tend to overeat. That may give you more bad results rather than intermittent fasting. So as of now, there is nothing to suggest that intermittent fasting helps in reduction of the weight. I'm talking about reduction of the weight and decreasing the weight. Overall, what matters is the total calories you consume in a day. preferably during the day.
There is one question by Dr. Vinita Jain, who asked that I've undergone few abdominal surgeries, and because of that I can't exercise, so how should I reduce weight?
Again, I think the most important component of the weight reduction in case you cannot exercise, there are two types of exercises. One is aerobic and second is a resistant exercises. So if you are not able to exercise, the type of walking, long distance walking, restriction of the calories should do good. If you're not able to lose weight, then you see the total calories you are taking in. And even if you're not able to do the resistant exercise, I think walking and gentle jogging may not be a contraindication. Restrict the diet and try to change over the type of exercise, which may not be a contraindication in terms of abdominal surgeries.
Then Dr. Jayanti Venkatraman is asked, what is the near infrared method? Is this machine available? How much does it cost?
Sir, to the best of my knowledge, I am not sure whether this is available in India or not. But bioimpedance, which is readily available and it can be done in the clinics. So that is the best suitable method for the assessment of fat in clinical situation.
Then Dr. Jayanti Venkatraman has also asked, are cardiovascular risk, etc., dependent on the site of fat deposition? I think it was answered by Dr. Anup Mishra, but this question has just come.
At this point of time, I would say that besides abdominal obesity, intra-abdominal fat, the most important ectopic fat, which is related to cardiovascular risk, is hepatic fat. And this has been shown in various studies worldwide, also shown by Naval's group in All India Institute of Medical Sciences, by indirect surrogate markers of atherosclerosis, which are correlating with the hepatic fat. So multiple fat depots may have lend cardiovascular risk, but the abdominal one and the hepatic fat remain the most important.
Dr. Nirja Chawla has asked, should we stop using BMI as a component of metabolic syndrome and use instead waist circumference or waist hip circumference ratio, as BMI does not differentiate between fat mass and muscle mass and SAT and VAT?
First of all, the definition of metabolic syndrome does not include BMI. It includes waist circumference, and the waist circumference levels are 90 and 80 centimeters for men and women in India. So metabolic syndrome excludes BMI. So there is no problem here. You continue to use. This second part is more tricky about your asking that waist hip ratio should be. Now there is a problem with waist hip ratio. Let me give you an example. Waist is 102 centimeters, so clearly out of line. And the hip is, because of the muscle mass being less over the hip, it is 80 centimeters. So the waist hip ratio is far too high, say 1.3, 1.4, or whatever it is. Now somebody has muscle also in the hip and fat also in the hip. So waist is 102 centimeters, which is high, and hip is 102 centimeters, which is high. The waist ratio is 1. So both are high, and waist hip ratio goes down. And one is high, the waist hip ratio goes up. So ratios have a problem, always have a problem. And that's why the waist hip ratio has not been given that primacy, and waist circumference has been given primacy. Only problem with waist circumference is the way we measure it. And we published a paper where we looked at 11 methods of measurement, depending on whether patient has eaten, patient is slouching while standing, whether he's exhaling, inhaling, and we found 2 to 5 centimeter differences in various methods. So that's why the exact method of waist circumference is what is required.
Then there is one question by Pranjal Sharma. I do not know whether he is a doctor or it is just a patient, because he says, I was suffering from NASH, but I am okay now. I want to know if the red meat is okay for me.
Ajay.
I don't know. I mean, as you rightly said, we don't know. I mean, NASH, how was the diagnosis made on him? Was it all non-invasive or did he undergo a liver biopsy? Number one. So that is the first question. The second is about the red meat. I think it's all amount to, when it comes to the calorie intake or the nutrition in fatty liver disease, it is again, ultimately we have to look at if he's overweight. I don't know what is his body weight and what is his, again, what is his waist circumference and the other metabolic parameters. But if he's overweight and if he has to lose weight, then obviously it is the combination of the diet and exercise, which means that he has to create a negative balance. He has to take less of calories. He has to burn more calories. And when we say about less of calories, this would include both carbohydrates and the fats have to be cut down at least by 30%. And that would obviously include the red meat also. So proteins he can continue. So as I said, I don't know about his body weight. Only then we can say how much weight reduction, how to do it and all those things. Yeah.
There are no more questions, but I would definitely like to ask, we had a small discussion on brown fat, beige fat and white fat. I would like to know what determines in body that the fat that we take in gets deposited as a white fat or a brown fat.
I think if I can, maybe others can add, but if I can answer, I think when we talk about the fat deposition, we generally talk about white adipose tissue. It's brown when we talk about bran fat. My understanding is it's predominantly it's involved in thermogenesis and has a totally different function. Whereas when we talk about deposition of fat and when we talk, I think it's the white adipose tissue. Maybe others can add on to that. And yeah.
But then what determines that fat will become brown or white?
I think the brown fat again has, if you look at the distribution of brown fat, it is not everywhere. It has a very select, places where we see brown fat. For example, they say above the clavicles, in the anterior part of the neck muscles, between the scapula. I mean, these are some of the areas which it's a very small amount of fat, and it's basically, and maybe around the vessels, right? Where I think which is involved in heat generation and thermogenesis. So I don't know what really determines and whether it's really related to the fat deposition per se, or I'm not really very clear on this. Maybe others can add on to that.
Dr. Mishra, would you like to say anything?
One thing.
Yes,
Yeah, one thing which is a clear determinant of brown fat is the temperature. And that's what the animals who hibernate have a huge amount of brown fat. And so they are living into a sub-zero temperature climate, and the brown fat increases in size. Once they go into hibernation, that itself is good enough to maintain the heat. So Indians, the human beings, don't have much of a brown fat. And yeah. Some people don't have a little bit of brown fat, and some people have more. Possibly genetic determination is there. For example, I showed you one slide where South Asians don't have much of a brown fat as compared to the white population. So possibly there is genetic determinant, possibly there is hormonal, especially catecholamines, and also temperature. And certainly diet has what component of diet we are yet to understand. Some components have been shown to change white to brown fat.
Dr. Anup, do you see a potential in therapies, be it dietary, exercise related or hormonal mediated, in which if you try to shuffle around from white to brown fat, that may be the game changer in treatment of NASH?
If you allow me, I'll share a couple of slides, if you allow me.
Yeah.
Okay. You have time, Anil?
Yeah, 5 minutes.
Okay, just hold on.
Anup, there are 3 questions for you waiting. So after the slides.
I'll just take 2 minutes.
Yeah.
And at the end of the talk, may I request Dr. Piyush Ranjan to please give us the summary of the proceedings for another 5 minutes before we end up. Piyush, please be ready.
So how can fat can be activated? This is one of my talks. And people are going to the North Pole or South Pole to activate. And there is a capsaicin. Look at this capsaicin. There is experiment that it increased brown fat. So that is one. The other thing is the catechin, which is in the peel of apple, and casein, which can increase the brown fat activation. Sorry, ursolic acid. This is a casein, and this is ursolic acid. Ursolic is in the peel of apple, which can increase. So these are the factors: cold, beta-3 adrenergic activation, cannabinoid receptor activation, estrogen, nutritional tea, catechin, and coffee, capsaicin, ursolic acid, resveratrol, melatonin, sildenafil, pioglitazone, and no, pioglitazone does not have, and sitagliptin also does not have. I put it because it was a diabetes-related talk. So you would know, some of these factors may act in us.
So we should stay in a cold place, drink a lot of coffee and tea, and possibly also take melatonin. Will that help?
Take sildenafil.
Maybe.
Eat the apple peel, not the apple. Peel off the apple, throw away the apple, and just have the peels. Is that the lesson?
Adaptive response to the temperature also. I mean, might be.
So there is a caveat in this also. Yeah. The methods which we have for the estimation of brown fat, they are not, always the same. Suppose if you are doing a PET scan for the estimation of brown fat for the same patient one day, and the next day, the amount of the brown fat estimated will be different under the same circumstances, under the same scenario. So there is a lot of problems with the estimation of brown fat. So you're not sure whether taking more caffeine or being in the cold place will increase your brown fat. There are two people, there are studies that if the same person exposed to the same cold atmosphere will show brown fat on single day and may not show brown fat on the next sitting. So there is a difference in estimation of the brown fat.
This is highly temperature sensitive also. Yeah. Also, those who are lean will have more brown fat, and those who are obese will have less brown fat. Whether it is cause or effect, we don't.
I have a question for Dr. Ajay.
Yeah, please.
Most of the studies have shown that it's visceral adipose tissue which is the male culprit. So is there any exercise or anything which we target mainly the visceral adipose tissue, like abs or something? So does it help?
See, again,
when we exercise and when we diet, the whole fat comes down and not specifically the visceral. So is there anything to target?
Again, I think if you look at the data, I'll again talk about the fatty liver disease. I think when people have people have basically looked at the weight loss or weight reduction with various modalities, whether they are lifestyle interventions or bariatric or anything. So I think people have mainly focused on the weight reduction and the liver fat, which actually comes down with weight reduction. Most of the studies have not looked into the kind of adipose tissue which has gone down with these exercises. But I think there is some little data which is available which have measured, both subcutaneous and the visceral adipose tissue, and they have shown reduction in both. But I think large studies are probably not available. People have just looked into weight reduction and the reduction in liver fat. Yeah.
One more question. Since you showed that sometimes visceral adipose tissue gets inflamed and then it causes. So has there been any surgical studies done that if they have removed like omentectomy or something? So if you remove the inflamed part, not the bariatric surgery, but just the removal of the inflamed.
I got your question. Yeah. But then again, I'm aware of these studies where people have done the liposuction and have removed the, subcutaneous fat, and that has not helped. Right? And that was an indirect evidence again to suggest that probably it is the visceral adipose tissue which is the culprit. But then the point which was very well taken was that subcutaneous is also divided into a superficial layer and a deep layer. So deep could still be a culprit, and whether those liposuction studies really remove the deeper layers of the tissue or only the superficial layers, I think that information I'm not aware. Secondly, I think about your question about omentectomy. Again, I'm not very sure, but I think there was some data which I remember offhand. People have done it, and but with not much of benefit. Yeah.
I'll just add to what Dr. Desita has said. There is no study which shows preferential reduction of abdominal fat with any lifestyle measure. However, if you lose weight in younger ages, then both will be reduced. If you lose weight in the 60s and 70s, there is a great resistance of abdominal fat not to go down. So you may still lose weight and you may not lose abdominal fat. So that is one. And the second thing, rightly said, that the liposuction studies, most of the liposuction has been done from anterior abdominal wall, never done from posterior because of the cosmetic reason. So anterior fat and superficial fat is removed, which has possibly no metabolic value.
Anup, there are 3 questions for you. How can we preserve the brown fat of infancy into adulthood? Can we preserve the brown fat which is more often seen in infancy?
Send them to Siberia.
Okay.
All I can say, if you are doing good amount of exercise, you're having a right kind of meal, you're possibly having a lot of apples and apple peels also, possibly you will be able to preserve whatever your body composition in the childhood, so you will be able to preserve. But I'm sure, although it is not proven, that junk food, plenty of saturated fat, etc., all will have impact on the brown fat. And if you increase your weight, it will be probably a white adipose tissue, and never a brown adipose tissue. So weight has to be maintained. If you gain weight, white adipose tissue will increase, brown adipose tissue probably will go down.
Okay. Second question, Anup. Recently in the European Association for Study of Liver, they said that better than the waist circumference, it's the neck circumference that correlates very well with non-alcoholic fatty liver disease. Are you aware of this?
Yes,
and
this is nothing new. Neck circumference we have been measuring for quite some time, especially in patients with obstructive sleep apnea. So measurement of neck circumference is the old thing, but correlation with the fatty liver is something which may be new. But I can say that it will this may not be entirely correct, because neck circumference may vary from person to person, and there is not great amount of fat in the neck, except in some kind of lipodystrophies, and it will depend on the bone and the muscle, which are quite a lot there. So I don't see how a fat there, which is possibly not metabolically active, will impact the fatty liver. I'm sure more studies are needed, Dr. Chawla.
right. And the third question is, do we have any Indian data on metabolically healthy obesity? What percentage of the Indians have metabolically healthy obesity? And as physicians, we should be speaking in these terms rather than generalized obesity.
Dr. Chawla, in 1988, Paul McKee did the experiments of how many obese people will have insulin resistance, and he said 80% will have insulin resistance. Those were the metabolically healthy people. Till now, any study anywhere in the world has not been able to negate this. This is the exact percentage everywhere. Now, but in Indian population, it will be probably less, because we are largely metabolically unhealthy, and it will be something like 90-10. But there is no robust studies. There are small studies by my colleagues which have been done. I won't say they are a very good study, so I can't quote them.
So we should have that data, and this could be some food for thought in the future.
Absolutely.
So I don't have any more questions. Anil Arora,
Maybe we request Dr. Piyush to please summarize the proceedings before we call it late.
Before I summarize, one final thing which I would like to ask: practically, if we see an obese person with fatty liver, how far would you go to investigate in terms of fat deposition, obesity, other than the routine BMI and waist circumference and the waist hip ratio? How far would you go? Would you do a CT for everybody to determine what would be the outcome?
Again, I think if I need to answer that, then, once the fatty liver has occurred, And we know that fatty liver is part and parcel of, the metabolic syndrome or hepatic manifestation of that. So I think when we look at the overall workup, what we do, obviously, if you look at only the liver workup, we would be more interested in knowing the severity of liver disease at that point, which means that whether he has only fat in the liver or inflammation, fibrosis, NASH with fibrosis, cirrhosis, whatever. So I think our focus is predominantly on that, and also to focus on all the other metabolic abnormalities that particular patient has, may it be diabetes, obesity, hypertension. So I think the kind of fat distribution will help you in making that diagnosis and all, but then assessment as such, whether it is the visceral or subcutaneous and all, probably would be more of academic interest, I would say. This is my thinking, rather than, anything adding on to your, management of that particular patient.
I would totally second that. I'll just add one quick remark here. For any assessment, leave aside liver. No further than BMI and waist circumference is needed. No further investigation. All we are all researchers. We are talking about the MRI, CT, etc. All in the research domain.
Research, yeah.
Dr. Praveen, what would be your take?
And sir, I totally agree, because even the simple anthropometric measurements like BMI, waist ratio, they have shown good correlation of abdominal fat with the other parameters like MRI, CT scan, and other things. Though they cannot differentiate between the subcutaneous and the visceral, but their association with the metabolic components like the future disease of CVD, diabetes, and other things, they have been well published in a large studies. So I don't think in a clinical practice we need to subgroup from the visceral and the subcutaneous fat. Till now, whatever literature we have.
So there we have the answers. We had 4 very wonderful lectures, and obesity, as we heard, starting from Dr. Anil Arora, the historical perspective, how the genetic predisposition has become a liability with probably the increasing availability of calories, increasing access to food, and that combined with our genetic makeup has led to this epidemic of obesity, which is continuing. And we all know obesity is related to so many diseases, including fatty liver diseases and other cardiometabolic diseases. And then we heard from Dr. Duseja what are the different types of body fat, and how does the inflammation of the visceral fat lead to progression of the disease and subsequent consequences. And then Dr. Praveen told us about various other tools which we have to measure fat other than the routine clinical examination we do. And then Dr. Anup Mishra pointed the fallacies of using BMI as the sole tool for sole index for defining obesity, and the other things which we have in the pipeline. And in the end, all of us agreed that despite the availability of these tools, they remain mostly in the domain of research and this thing. And we look forward to having more data in the future when we can use this different body composition in the prediction or prognosis, or in temporarily with the progression of the disease. How does this help us to better understand the clinical correlates of all these conditions? So with that, I would like to close. Dr. Anil, if it is okay. Ashish?
Yeah. Thank you, Dr. Piyush, for very well summarizing the whole presentations today. And I'm thankful to all the speakers, Dr. Anup Mishra, Dr. Praveen, Dr. Ajay Duseja, and the moderators, especially Dr. Chawla and Dr. Anand, for making this as a wonderful discussion webinar. And we invite you for our 3rd webinar on obesity after a month. And the title of that will be, once we have decided that this patient has abnormal fat deposition, this needs treatment, what are the medical avenues to get over it? With that, I close the session, and I'm thankful to the organizers and our pharma partners, Microlabs, for having given us this platform, which was very smooth and very conducive. Thank you so much. Good night and goodbye to all of you.
Thank you. Thank you. Thank you very much.
Thank you. Thank you.